Hello everyone, this is Chadi from CVI 2023 in Austin. Really privileged to be with Dr. Bill Fearon to talk about the future of physiology. Phenomenal talk, Bill, at CVI 2023. So you enlighten us about what to expect from the data we have and how we're going to use this physiology in the future.
Sure, yeah, well thanks for having me first of all. I think there's a number of areas physiology is moving in the future. One is sort of a more universal application of physiology throughout our procedures. You know, traditionally FFR or IFR were used basically to identify intermediate lesions that we could defer safely. But now we're seeing it being used in much more complex patient subsets. For example, like in the FAME-3 trial, comparing FFR-guided PCI and multivessel disease, routine measurement versus CABG. So that's one area. I think also throughout the PCI procedure, so not just pre-PCI, but post-PCI FFR or IFR, and then also using it to help us decide what the best strategy is. So doing pullbacks and using various indices like pullback pressure gradient, PPG, or IFR co-registration so that we can distinguish focal from diffuse disease, with knowing that the focal disease will respond better to PCI, where diffuse disease might be managed more appropriately other ways.
So I just would like you to emphasize more on the PPG or pullback gradient.
Yeah.
It's a new concept. I'm not sure, it's easy to do, but I'm not sure an operator would be familiar with how to use it in clinical practice, if you can focus on that.
Sure. So basically, it's an index that's measured during hyperemia, so it requires intravenous adenosine, and you slowly pull the pressure wire back. It's currently only available on the Coraventus CoreFlow system with the Abbott system. And basically, what it's doing is integrating the change in pressure over each sort of 20 millimeter segment, and then quantifying that change in an index where 1.0 would be totally focal disease and 0 is diffuse disease. And so if you have a value of 0.3, that PPG of 0.3, that means it's more diffuse disease, less likely to get a high post-PCI FFR, less likely to have improved quality of life, whereas if you have a PPG of 0.8, that's a very focal lesion where you'd have more likely a better response and a higher post-PCI FFR.
The second item you mentioned in your presentation about the functional FFR and how this subgroup analysis that's done from FAME-3 kind of show favorable outcome or close to favorable.
Yeah, this is something that I feel is an important point about using physiology when we're trying to decide whether to send a patient for bypass or PCI. And you know, we have things like the anatomic syntax score, which is clearly very useful if you have a low syntax score, less complex disease. PCI generally performs quite well, the reverse for complex disease. But I think we can get even more granular information by measuring physiology and calculating what we call the functional syntax score, which is basically the syntax score minus any vessel that has a negative FFR. And so by doing that, you can simplify your procedure. You can convert a 3-vessel disease patient to 2-vessel or even to 1 vessel. And in the FAME-3 trial, we found that patients with a low functional syntax score, which it turned out were half of the population, had very favorable outcomes compared with PCI. And so I think this is another way of incorporating physiology to allow us to more appropriately decide revascularization strategy.
And that will help also discussion with the surgeon and the patient as well, to kind of facilitate which option of therapy they choose or they recommend.
Yeah, exactly.
Yeah. Well, Bill, thanks so much for being with us and for enlightening us about important physiology updates. And please watch these videos and others on CVI YouTube channel. This is Chadi from Austin from CVI 2023. Bill, thank you so much.
Thank you.